Because we have so many topics that we're going over this week, I wanted to make sure that I included cardiomyopathy, but not necessarily in the lecture standpoint, because it does tie in very closely to congestive heart failure and it overlaps with the structure of the heart. But I definitely wanted to make sure it got covered. So if you look at cardiomyopathy, it is what it looks like. It is a disease of the heart muscle. So cardiomyopathy, right? That's what it actually is. And what that means is it's an abnormal structure. I'm going to slide myself over here. The heart muscle itself changes how the heart works. So if you look in your book on table 31.9, it actually breaks them down, and yet there's a side by side comparison of the different types. But there's two different ways that it can occur. One is primary, which is what we call idiopathic. We don't know, it just happens. We find it, it's there. The other is secondary, and we know that is a development of another process that then causes the heart muscle to change. So one is organic and one is acquired. So three different types that we will typically talk about. We're going to talk about dilated, hypertrophic, and restrictive. Dilated, we're going to talk about probably the most. That's what you're going to see the most. 85% of your cases of cardiomyopathy are going to fall in that dilated category, right? This is a contractility problem. This is the ability of it to actually squeeze. This is a common cause of heart failure, right? We just talked about heart failure, how the muscle changes in shape and that affects its cardio output. So when we think of the dilated, we're thinking of something that's stretched out, overstretched, that loses its ability to recoil. So I think when we talked about cardio, um, what about CHF? We had that deflated balloon, right? He'd been overinflated, then which is kind of floppy. So this is where it starts to thin out, and because it is so dilated, which means enlarged, and that muscle becomes thin and it's not able to squeeze. So again, poor cardiac output as a result of the inability to contract. And if you look at this picture here, you can see a normal heart on the left. You can see on the right how that ventricle has gotten engorged. It has stretched out. You can see the ventricle, the left ventricle is much thinner. And oftentimes we see this present itself as heart failure, cardiomegaly, an enlarged heart, or dysrhythmias as the conduction system is also stretched. It affects more than just the muscle. So we do have these three things. And again, we just talked about heart failure, and we can see where this ties in very nicely. The second type we're going to talk about is hypertrophic cardiomyopathy. This is a genetic component. Okay, so a lot of this, 50% of the people, this is genetic, meaning it just occurs, right? That means obviously the other 50%, it can come from some type of a disease process that causes that muscle to thicken. So this is a thick wall problem, right? Which stretch that preload. So it doesn't stretch out and it can't squeeze as much. So that end diastolic volume is decreased. So decreased preload, decreased in the amount of blood that can get into the chamber and then be ejected out, right? In our younger population, in our young children, in our teens, when you hear of people having sudden cardiac death, right? People on the football field or the basketball court, this may be the first sign of the fact they have this hypertrophic cardiomyopathy where they cannot maintain the cardiac output, which then causes the heart to fail. So increased thickening of the ventricle. When you take a look at this is a cross section, and you can see that septal wall all the way through the ventricle. It can be on either side. Typically starts on the left, and the right will compensate by getting larger. And we see this. We see dyspnea. We see angina, right, which is that chest pain, and we see syncope, right, where we're not able to meet that demand of the body. So you can see where in an athlete, this would definitely cause a problem. The last kind is called restrictive, and you're not going to see this as much, but it is a problem with the ability to fill. And this is a change in the quality of the heart muscle. So it doesn't get any bigger, doesn't squeeze any less. So it's still able to do its things. It's just the muscle in the heart becomes fibrous or very, very stiff. So it is still beating, it just can't stretch to fill. So it becomes very, very rigid. It can be caused by some type of scar tissue or fibrosis, or amyloidosis, which is a condition where there's a buildup of protein that like embeds itself in the muscle, which then impacts its ability to stretch and move. So very, very uncommon, but you can see in this picture here that the size is the same, right? You can just see a difference in the quality of the cardiac cells as they're being replaced by fibrous tissue. And we do see this as a result of heart failure, right? Because that is not able to perfuse, and it also creates a difficulty in the cardiac output, obviously, right? It's not able to send out the amount of blood because of that wall stiffening. So when we talk about cardiomyopathy, it mimics most of the symptoms of heart failure. So you're going to see all the things that we talk about with our heart failure patients. So decreased output, poor perfusion, they're going to fatigue easily, activity intolerance, short of breath. Because of the stretching, because of the change in the muscle itself, you're going to have some dysrhythmias. We talked about the S3 and S4 heart sounds. Those are extra sounds that we have because we are so fluid overloaded. It's pressing against those valves, and so those valves are making some extra sounds. We may have some jugular edema, pulmonary edema. So all the things that we would think of with heart failure, because the heart is in essence failing due to the change in the heart muscle. Excuse me. So the diagnostics that we use are going to be very similar. The echocardiogram, that's where we do the ultrasound of the heart to look at the chamber size, the wall motion, the valve function, the chest x-ray. If it is an enlarged heart, we'll be able to see that. We'll also be able to see the pulmonary edema. We talked about hemodynamics, right? So this is our pulmonary artery wedge pressure, which is what is the pressure building up behind or going into with the cardiac output. We also want to look and see what the blood flow looks like. Will we have this enlarged muscle or this damaged muscle? Do we have perfusion? Is the heart actually feeding itself? And in cases, especially with the fibrosis, they can take a biopsy of the muscle and actually check the quality of the cells and see what's happening there. Here's just a side-by-side comparison if you want to do all four. And you can see the normal heart in the top left where it comes to dilated, hypertrophic, and the restrictive. So you can see kind of the differences where you see from the normal to the restrictive, you don't see a lot of external factors, but that's more the interlining of the myocardium. So how do we manage this? We focus on supportive management where there is no way to cure it. Very similar to CHF, you're going to see very similar medications, right? Our ACE inhibitors, vasodilators, our digoxin, our positive inotropes, beta blockers, anticoagulants, because it's not pumping like it should. We're at risk for thrombus. We don't want to give antiarrhythmic drugs unless we absolutely have to. Because we do have a more irritability in the heart, and that can actually lead to other problems. There are some surgical options we can take. We talked about, when we talked about treatment of dysrhythmias, we talked about a biventricular pacemaker where they go in and they resync so that the ventricles beat together for severe CHF. And because of those dysrhythmias, we may need to put in an ICD, okay, not just a pacemaker, but implantable cardiac defibrillator. We talked about a VAD, a ventricular assist device that might work as a bridge, kind of buy us some time until we get to the heart transplant, which is really the only definitive treatment. Unfortunately, for cardiomyopathy, the restrictive characteristics we cannot treat with a heart transplant because that whatever underlying condition caused the fibrosis of that muscle is still going to be present. So that is not going to be an option. What they can do for some of these, especially the hypertrophic, is they can go in and actually thin the muscle size, which helps to open up and make the chamber size bigger, which increases the cardiac output. And if they are diagnosed with this hypertrophic cardiomyopathy at a young age, they may have to have multiple surgeries of this throughout their lifetime to kind of go in and clean out some of that excess muscle to allow that the ventricle to fill. Had a student that was in clinical whose father was diagnosed with left ventricular hypertrophy, and she started having some symptoms. She was having some syncope, she was having some shortness of breath, and they went in and they tested her and she had it as well. So when she would come to clinical, she would sometimes become very fatigued. She would sometimes have syncopal episodes or feel incredibly short of breath. She'd get cool and clammy, because her heart was just trying to keep up with what she needed. So she was actually able to get a surgery, the thinning, right, to go in and to kind of like open up that chamber a little bit. And while she was in the hospital, she was such an awesome person and was so interested in asking so many questions. She actually got a job on that open heart unit once she graduated from nursing school. She's amazing. So, it can impact quality of life, but we also can have some positive outcomes as well. So in our nursing care, with our dilated and our restricted, we see all the things we would do with congestive heart failure, right? With our hypertrophic, because of the increased cardiac demand, the perfusion demand for the heart itself, we get symptoms that are similar to myocardial ischemia. And so we treat these the same. So whatever care plan you would use for CHF, you would go for the first two. Whatever care plan you would use for myocardial ischemia, you can do with a hypertrophic, except that we don't want to vasodilate. We don't want to use nitrates. We don't want to use vasodilators because we're already struggling with that cardiac output. Okay. As well with the hypertrophic, we have to talk about the genetic connection, and we need to make sure we're talking early and often about what criteria will get us to the point where we need to have that open heart surgery to go in and reopen that left ventricle or right ventricle, depending. All right, so lots of quiz questions we're going to do on these just because I want to make sure we have plenty of time to practice. These kind of tie it all together. So if you need to, you can go ahead and hit pause and read through these and then come up with your answer. So if you're a nurse working with a client taking a beta blocker, and we understand that the beta blocker works in what way, right? How do they work? So go ahead and hit pause, read through these. And the answer is A. Beta blockers actually block the effect of our epinephrine, or adrenaline, which allows the heart to be low and slow, low heartbeat, less force, nice and eased up on the workload, right? So that's what we know about a beta blocker. If a client with heart failure receives an echocardiogram and it shows the heart muscle has been damaged and has grown very thick as a response to high blood pressure, right? That high pressure, the muscle has to squeeze harder to beat against it. What is the most appropriate term for this condition? And again, the answer is B. So hypertrophic is the excess growth, where we have that real thick wall, and is inability to open up enough to let blood in, and it causes some symptoms where we have that decreased cardiac output. If you're caring for a client with a history of CHF and you're reviewing the medication list, and the client says, which medication is he taking that is for CHF? So, which one of these four very similar C sounding medications is used for CHF? And the answer is B. That would be the captopril, which is an ACE inhibitor. We use it for high blood pressure and CHF, and we know that it ends in pril, right? And we remember with those ACE inhibitors, our side effects are often a cough, a dry, nagging cough. And we do have to be careful because they can cause angioedema. Even the people who have been on it for quite some time, years even, they can suddenly develop angioedema that needs to be treated so it doesn't so it doesn't progress. I had that happen this summer. I had a gentleman who was volunteering at a camp I was volunteering for, and at the breakfast line, he showed me his lower lip was nice and swollen. I said, Do you happen to take an ACE inhibitor like a lisinopril?" "Well, yes, I do." So by the time we drove into town, he had some swelling everywhere. So we just need to make sure that we are using our nursing judgment and we are educating our patients when we prescribe a medication. Which of the following best describes the purpose of a ventricular assist device? The answer is D. We use it for a weakened heart, and it helps to pump the blood from the ventricles to perfuse all the organs and tissues and assist the heart. You can use it in either side, it doesn't matter. But we usually use this again as a bridge while we're waiting on a heart transplant. All right. So hopefully that gives you an idea of what we're looking for, some practice questions. It gives you a little overview. Not a lot of information in your book, but hopefully you get the gist of what cardiomyopathy is.